Okay, so let's then talk about concepts surrounding pregnancy and the kidney. The way I approach this is, I think the topics, the way I approach this is really what are the normal physiologic changes throughout the course of pregnancy, and then on to sort of the problems that you face as a nephrologist managing pregnant patients. And that would certainly include acute renal failure. And then what are the outcomes for patients who have chronic kidney disease and pregnant? Because they want counsel from you on, what are the risks to me and my renal function, and what are the risks to my baby? Those are really the things that I hope to hit in this discussion. And then I have a little bit here on the back end on treating the individual complexities of lupus nephritis in pregnancy, diabetic nephropathy in pregnancy. There's not a whole lot to say about that. And then dialysis in the pregnant patient, we can certainly talk about. Renal transplant patients, well, I guess I have more here than I had originally planned. I guess I have to be thoughtful in how we're going to attack this. Okay, so let me try and do that. Whoops, it's my placeholder. Sorry, I'm trying to open up my other device while we're starting this as well. Okay, so then I think I probably should shave off on some normal physiology on the pregnancy to make sure we can get to some of these pathophysiologic disease states. So I'm going to hit some high points on the physiology of pregnancy that are clinically relevant. Notice that you're going to have hydronephrosis that is apparent on renal imaging. And so don't be thrown off by that imaging finding. That is the vasorelaxant effects of progesterone that affects the urinary tract as well. So be aware of that. There's also a change in hemodynamics that's notable during the course of pregnancy. And typically, blood pressures drop throughout pregnancy. And that is, again, some of that relaxing effect of progesterone and another mediator called relaxin that is derived from the corpus luteum, as well as the placenta. But there's another mediator of that effect. Essentially, the placenta is a large AV fistula, you can say. So that reduces the resistance in the vascular bed, and such that you get a drop in blood pressure and an increase in cardiac output. So that is, again, notable, that those vasorelaxants, that AV fistula, that is your placenta, is results in a reduction in systemic vascular resistance. So blood pressure falls, cardiac output increases. Okay. I'm going to skip through some of the other things noted there and go to changes in aldosterone. This actually comes up, not rarely, where we think about, hypertension in the pregnant patient, why a young a female who's pregnant may be hypertensive. So you think about checking aldosterone levels in a pregnant patient. We had a very interesting case recently with, I think Mauricio was running point on that case, where he was interrogating a case of Geller syndrome. So where we have this unusual activation of the mineralocorticoid receptor by progesterone. So the reality is that in normal physiology, progesterone, um, uh, excuse me, I'm still trying to join on my other device, our meeting here today. In normal physiology, progesterone antagonizes aldosterone at the mineralocorticoid receptor. And so there's a normal physiologic response where aldosterone levels increase several fold throughout the course of a normal pregnancy. So if you try to use aldosterone, hyperaldosteronism, in order to interrogate a case of hypertension during pregnancy, you will be confounded by this normal physiologic increase in aldosterone. Part of that, again, is because progesterone antagonizes aldosterone at the mineralocorticoid receptors, so you have an increase in aldosterone levels, but also some of this reduction in SVR and a reduction in effective circulating volume, right? Circulating volume is actually increased during pregnancy, but the effective circulating volume from this drop in SVR also tends to stimulate the RAS system, including aldosterone. Okay. You've, of course, know about respiratory alkalosis. I won't belabor that. There are normal changes in tubular handling of various solutes that you should be aware of. One of the more important or clinically relevant ones is a modest increase in proteinuria throughout the course of a normal pregnancy. So if you see a dipstick that's positive during pregnancy, be aware that this is something that may be normal. So we allow up to about 200 milligrams of protein in the urine in the pregnant patient that and still be in the normal range. I get, some of you know I do some of these virtual consultations at Parkland. Not infrequently do I get a virtual consult for proteinuria in the pregnant female, and you just have to highlight some of the normal physiology during pregnancy. Notice also that it's not rare that you also have a little bit of a glucoseuria, even though the patient may not be diabetic. Okay. So I'll say one last point about normal physiology, and that is the normal modest reduction in the set point for serum sodium. For patients who are pregnant, typically you have a reduction in the serum sodium. You can see that it's some of the common mediators of changes in maternal physiology. Relaxin also seems to be important for this phenomenon of reset osmostat that results in a modest reduction in the serum sodium. Okay. You can read through this to review some of the, I'll just go through it. So rarely you can have a diabetes insipidus that results during, which is the flip side, right, of what we just discussed, where most commonly the serum sodium drops throughout normal pregnancy, but occasionally you can have the flip happen, where the placenta actually metabolizes vasopressin, and that would result in a diabetes insipidus physiology. Now, typically, that's a rare phenomenon, but it can be part of the normal physiologic change in a minority of patients. Some things that might increase the likelihood of having this is really twin pregnancies where you'll see a larger than average placenta, where vasopressinase activity might be predicted to be higher than the normal single gestation pregnancy. Now, interestingly, and maybe for a board question, if you have this excess of vasopressinase causing DI physiology, that vasopressinase cannot cleave desmopressin. And so giving exogenous desmopressin would resolve this physiology of diabetes insipidus. You can get apoplexy. You may recall from your med school step 1 reading, that would be another way that one can get a diabetes insipidus physiology during pregnancy. Questions about those physiologic changes before we go into these pathophysiologic phenomenon that you may encounter during pregnancy? All right.
Dr. Sam?
Yeah, go ahead, Sarwar.
You were saying the consults that you get on proteinuria and pregnancy, do you just see like dipstick, like proteinuria, and they say, hey, there's dipstick, and then do you tell them to get a 24-hour urine? How do you approach those, and what
Yeah, you will get consults probably for both. I get consults for both. For 24-hour urine proteins, they're modestly elevated. The dipsticks that are modestly positive. Remember that your dipstick can sometimes be more than trace positive, because sometimes your patients have profound nausea, hyperemesis gravidarum of pregnancy. And so their urine can be quite concentrated. So the giveaway is the specific gravity is very high on that UA. And you can see more than a trace or 1+ positivity when the patient is truly, maybe volume depleted or at least dehydrated, not having drank much fluid. And so dipsticks and 24-hour urines are often drivers of that clinical question. This might be an opportunity to talk about protein to creatinine ratios in the pregnant female and whether those are valid estimations of proteinuria in the pregnant female. The answer to that is probably yes, they are still valid measures of 24-hour urine protein or estimates of 24-hour urine protein. However, the history or the literature in the OB literature is primarily driven by 24-hour urine protein testing. So you'll see our OB colleagues are mostly relying on 24-hour urine proteins, but certainly a protein to creatinine ratio appears to be a sound means to estimate proteinuria. Interestingly, our colleagues in OB will sometimes leave out often I would say, leave out the 24-hour urine creatinine. In that regard, sometimes you will overestimate or underestimate the protein because it's in an incomplete or over complete 24-hour urine. So that's another, question that sometimes I get. I get a standalone proteinuria and before I get too excited about it, unless it's 3 grams. Before I get excited about it, I just say, well, we didn't get a creatinine with this, so this may even be an overcollection, and this 400 milligrams of protein is not something to get excited about yet. Make sense?
Yep, thank you.
All right. Okay, so then let's go through some of the clinical syndromes of acute renal failure that you may see during the course of a pregnancy, and there's several to be aware of. Okay, so the ones that sort of overlap are TTP, HUS, and the HELP syndrome. Okay, and Shota, I think I see that you've joined. Sorry for this last minute addition to your schedule. This is not obligatory for the first year fellows. It was sort of an inadvertent email to the first year fellows by Jonathan. This is a low stress Escolitas session. We talk about some administrative aspects of the program, but if you've got other things to attend to, by all means, peel off. But you're welcome to stay with us. Yeah. All right. So HELP, excuse me. So I was saying TTP, HUS, HELP are the typical things that are overlapping that one needs to parse through. Okay. So how do we parse through these? Well, let's first talk about the pathogenesis of these individual syndromes. You, of course, know that TTP is a deficiency of Adams TS13, and sometimes it's not a protein deficiency, it's simply a activity that is deficient. So many times, as I would say most times, Adams TS13 levels are normal, but its activity is low. And the most common thing that we see is through the production of an autoantibody that becomes an inhibitor of Adams TS13. So the classic scenario in which this happens would be a lupus patient, where one part of their presentation is actually TTP. So certainly our patients have thrombocytopenia for a number of reasons. One possibility is that it's an acquired TTP from an autoantibody that is inhibiting Adams TS13. The assay that we utilize is typically an activity assay, not a level. And so you'll see an Adams TS13 activity that is low. So maybe this deficiency should be more qualified as not so much a deficiency of Adams TS13, but a deficiency of its activity. Okay. Keep in mind that there is a normal decline of Adams TS13 throughout the course of pregnancy. And so this is why perhaps TTP has a higher incidence in the peripartum period. Okay. If you have, let's say, an underlying deficiency of Adams TS13, let's say you've had an inherited deficiency of Adams TS13, or you have let's say, a weak or moderately strong inhibitor of Adams TS13. Well, now you have the second hit where you have pregnancy and a normal decline in Adams TS13 production, and then the perfect storm is initiated, where you develop frank thrombotic microangiopathy. Okay, perhaps there's a teleologic explanation for why Adams TS13 activities drop throughout pregnancy. At least this is how I remember it. The mother is preparing for a hemorrhagic event, and so it makes sense then to enhance platelet function if you're preparing for that hemorrhagic event. And so there's this normal decline in Adams TS13 throughout the course of pregnancy. HUS is predominantly grounded in dysregulation of complement, and so we think of HUS as often a two-hit phenomenon as well, where you have some underlying complement dysregulation, and now I have an event, an inflammatory event that sort of tips an underlying dysregulation in complement to unopposed complement activation. So that precipitating event can be an infection. It can be pregnancy, where I tip an underlying predisposition to complement dysregulation into unopposed complement activation, and then thrombotic microangiopathy. We don't quite understand why HELP occurs. I think the simple conceptualization is that it's just a very, very severe form of preeclampsia. We'll hopefully talk a little bit about what is the underlying pathophysiology of preeclampsia in a few minutes. Okay, how do we distinguish these entities of acute kidney injury characterized by low platelets, okay, and then varying degrees of hemolysis? Well, again, all of them present with that hemolysis and thrombocytopenia. If you had some way to discriminate them, here are some timelines to keep in mind to discriminate them. We typically see that TTP happens kind of in the middle of pregnancy. So if you want to characterize that as roughly second trimester, you of course can have TTP in the late part of pregnancy and even postpartum. So these are not hard and fast. These are general trends. Okay, so TTP happens a bit earlier, HUS happens a bit later. So those are some of the take-home messages to sort of try to stratify your pretest probability for these individual possibilities. Okay, now HELP syndrome, if we think of it as, again, the most severe manifestation of preeclampsia, we typically see preeclampsia after 20 weeks. There's rare instances where preeclampsia has been described before then, and that's typically in abnormal pregnancies, twin pregnancies, or in molar pregnancies, things where the placental implantation might be particularly abnormal. Okay. TTP and HUS typically have profoundly low platelet counts, single digits, less than 10, certainly less than 20 is really a common manifestation for TTP and HUS. HELP would tend to have less severe declines in platelets. HELP has more proteinuria. The proteinuria that is manifest from TTP and HUS is often driven by just hypertension. So hypertension, uncontrolled hypertension of any cause, would typically cause proteinuria. It's a way, for instance, that malignant hypertension manifests. But the HELP syndrome, by virtue of it being on the spectrum of preeclampsia, would characteristically have more proteinuria. Okay, the liver enzyme abnormalities are a unique feature, fairly unique feature for HELP. You don't typically see marked elevations in liver enzymes for TTP and HUS. Of course, HUS, as the name implies, typically has a prominence of renal failure. Okay, treatment is usually, urgent delivery. Okay, so that really is at the heart of how we manage all three of these. Of course, with TTP, you're also thinking about plasma exchange to replenish normal Adams TS13 activity. With HUS, we're leveraging complement inhibitors. And then with HELP, we're really just using urgent delivery and the magnesium to manage the severe hypertension and the predisposition to convulsions, right? So any questions about TTP, HUS, and HELP before we go on to I'm not going to say too much about acute fatty liver, since that's primarily a hepatocentric disease that essentially has acute kidney injury from somebody who has, a severe hepatic injury, or even in some cases fulminant hepatic failure. So the AKI to be aware of in acute fatty liver is really just an ATN, that somebody with profound liver injury. Okay, so no further questions about acute kidney injury in the in the peripartum period. All right, then let's move on to chronic kidney disease and pregnancy. This is certainly a very ripe area of nephrology that you will use. You'll need to have this ability to counsel your patients through their difficult decisions surrounding pregnancy. I guess I have to sort of, you know, I have to highlight recent changes in Texas law and in a number of states that are politically conservative, that now, the decision between you and your patient surrounding pregnancy termination for maternal health is a much more complicated one. It was already complicated enough, but now it's even more complicated by the political landscape that is the reality here in Texas and in other states that have become really restrictive with abortion. So it's not impossible that you can still justify pregnancy termination even in the state of Texas under the laws that are now in effect. It essentially requires that you prove either the mother has a real risk of loss of life, but the other caveat that is allowed, or is that is highlighted in the law, is really less clear. It's significant morbidity or loss of limb, I think, is how the law is phrased. And so I personally have engaged with our OB colleagues and our attorneys at Parkland on how we have to parse this. And I've actually, I've walked this walk in every year, including this last couple of years with Texas law that's changed. We have to parse through an unplanned pregnancy. In fact, now I will even highlight, I have a stage 4 CKD patient from GN Clinic who 2 weeks ago told me she is now pregnant. So this is something that, really we have to wrestle with. And then there's a lot of documentation that's required that highlights the risk to mother. And then one can actually go forward with pregnancy termination, even in the state of Texas. Questions about that political landscape, which is complicated, before I go into sort of the medical aspects? All right, then. Let's talk about the medical aspects that you'll need to counsel your patients on. So one thing to be aware of is don't be surprised as proteinuria worsens throughout pregnancy. So if you have already CKD with proteinuria, you can expect to see about a doubling of the proteinuria during the normal physiologic changes of pregnancy. So we talked about how even in the normal patient, they may manifest a little proteinuria. So you get a hyperfiltration during pregnancy. I guess I didn't highlight that sufficiently. Let me just go back here. There is about a 50 to 100% increase in GFR that happens throughout the course of pregnancy. So that happens where renal plasma flow and GFR increase in the normal pregnant patient. And so you could expect that if you have proteinuria and now your GFR is increased by 50%, that filtration of protein is accentuated. So that would be one reason why, again, you would predict proteinuria increases throughout the pregnancy, simply because per unit time, I'm filtering more across the glomerular filtration barrier, okay? So if I have 1 gram of proteinuria and it goes up to 1.5, 1.7, I don't get too excited about that. I prepare the patient for that. And I also prepare the other providers for that, because many times you use proteinuria to make a decision that this patient is manifesting preeclampsia. And so you have to anticipate that proteinuria is going to increase. And if proteinuria is increasing, don't overcall preeclampsia just because you see this increase in proteinuria. Okay. So I use as a rough threshold, doubling of the proteinuria is where really things are unusual and indicate potentially some pathophysiology or new pathophysiology at play. Okay. Now, there is a risk of progression of worsening renal function throughout the course of pregnancy. Now, it's pretty unlikely in the CKD patient who has a creatinine of 1.5 or so or better. Okay, and this is important. So you're generally, if I have a patient who has CKD, creatinine's 1.3, 1.4, I would generally give them an optimistic view of what their personal prognosis is with respect to this pregnancy and its effects on their renal function. I would generally sort of, if you want to put it this way, green light it, right? If they're telling me, doc, I really want to build a family, if their GFR or their creatinine is in this range of 1.5 or better, I would generally give them a positive outlook on that. I would still say we need to follow you closely. You have to see high risk OB, you have to see me, but I think that this is something that is a reasonable goal with low risk of adverse outcome to you. Okay. Now there is another modifier to be aware of, and that is the degree of proteinuria. If I had a nephrotic patient with a creatinine of 1.3, that would be a more difficult sell, where I would certainly I would convey caution and really a less positive prognosis for them. But the reality is we don't have as much data as we have on serum creatinine for the influence of proteinuria on maternal outcomes with respect to their renal function. So we just have a paucity of data. It does seem to be a modifier. The threshold is about 1 gram, but we don't have good evidence to say, well, what if you have 3 grams or 5 grams or 6 grams? I could just, my gestalt is that is certainly a much more risky pregnancy for the mother's renal prognosis, as proteinuria more broadly is a risk factor for renal disease progression. Okay, but so this is all old data. It comes from old series of maternal outcomes, but it's benefited by what are hard clinical outcomes for your patients in terms of doubling of serum creatinine or worsening GFR that is approaching ESRD. So this is, limited by it being old data and serum creatinines as opposed to GFRs or even eGFRs. But it's benefited by looking at long-term maternal outcomes and these varying degrees of CKD. When you have a creatinine greater than 1.5, that's when you can say that about a third of the patients, this is what they're probably most interested in. They're not so interested in the fact that they may have a transient decline in GFR that recovers. They're more interested in what's my likelihood of having a permanent loss of GFR by being pregnant. And so it seems at the threshold of 1.6 and above, that's when this there is this more meaningful risk in permanent loss of GFR. It certainly is more with more severe degrees of CKD. So I highlighted the patient that I'm managing currently who has a CKD4. I told her she has about a 50% chance that she's going to, need dialysis during the course of this pregnancy. She's now first trimester, and we're trying to sort out what is the right direction for her health. Okay, so 1/3, again, show a permanent loss of GFR. You certainly can estimate a higher risk of loss of GFR for these advanced stages of CKD, stage 4 and 5 CKD. Excuse me, stage 4 CKD, you can certainly say that it's over 50% likelihood that you're going to have a permanent loss of GFR. Okay, now certainly the mother is also worried about their well-being and health, but they're obviously also going to be asking you questions about what is the risk to the baby. And what you can tell them, the things that are clinically relevant for mom to calculate what to do next is, what are the things that are going to result in morbidity for my unborn baby, and that is the risk of premature birth is one thing. It's not a big deal to be premature by a couple of weeks, but it's important to know when that baby is going to be born before, especially this 34-week threshold, where if the baby is born at before 34 weeks, you can plan for them to be in the NICU. So they're going to need several weeks of NICU stay. And that's when, we can call that, let's say, very preterm birth. But you can certainly say that for any CKD patient, even mild degrees of CKD, there is clearly an increased risk of preterm delivery. There's also a small for gestational age as a outcome, and there is certainly a risk for fetal demise. For the patient, again, who has stage 4 CKD, I estimated for her that there's greater than 50% likelihood that actually, even if you choose to keep the baby and not terminate, that this will not be a successful pregnancy regardless. Okay. Now, if you want to do best to improve the outcome for the baby and the mother, what you really need to focus on is blood pressure control. And what is borne out by the literature is that the earlier you control blood pressure, the better the outcome for the mother and the baby. Of course, there's some bias in that analysis because the well-controlled patients are generally, very compliant. The early well-controlled patients are going to be very highly engaged with their health and compliant. That being said, this is still a good, a clinical pearl or point to make with your patients that if you're going to plan to be pregnant, then let's get your medications, let's get your blood pressure optimized. So at the time of conception, your blood pressure is still well controlled, and that would increase the positive outcome likelihood for you and the baby. Okay, so that's really your primary tool that you have. Of course, you need to peel off the ACE inhibitors, etc. But despite those medication changes, you'll need to pursue really good blood pressure control. And let me say, I guess, as part of that, that what is good blood pressure control? The general trend over time is to get the blood pressure essentially less than 130/80. I would say is a pretty good um, uh, collaborative target for you when you're co-managing blood pressure with OB. So historically, OB has been very conservative about blood pressure management. They used to worry about placental insufficiency and sort of have blood pressure targets. Well, if the blood pressure is less than 160, we don't have evidence that it's improved maternal outcomes. We would worry about placental insufficiency if you drop the blood pressure below that. There have since been randomized controlled trials that tried to answer the question, is there any harm for lowering blood pressure below for the hypertensive pregnant patient below those traditionally conservative targets. In essence, those studies, although limited, showed no positives from lowering blood pressure, but showed no negatives from lowering blood pressure to kind of 130/80. So I think now you can make arguments and be working in the same direction of getting patients' blood pressure down to 130/80. Another question that often comes up is, can you use diuretics during the course of pregnancy? The general bias for your OB doctors is going to be limit diuretic therapy, but you're going to be co-managing nephrotic patients who are pregnant, and you absolutely still need to at times be using diuretics. Diuretics are not contraindicated during pregnancy. What you're trying to avoid is frank volume depletion and placental insufficiency, but you can absolutely still use diuretics. They are not known teratogens except for the possibility of, causing placental insufficiency if you're over aggressive with diuretic therapy. Okay, but you should not be avoiding diuretics in managing the CKD patient who has nephrotic range proteinuria and massive edema. Management, again, get the blood pressure under control. And then many times it's a discussion that you engage with your OB colleagues on. What I think is important to know as you as a nephrologist who is seeing the nephrology condition through the lens of what is good for mom and what is good for baby, you have to think about this aspect of what is good for baby. And that is, if you can get the delivery or the pregnancy to 28 weeks, let's say you have a lupus patient and things are looking, pretty dicey. But if they're close to 28 weeks, what you might do is, hold back on some of these toxins that you may be considering, or other interventions that would put mom or baby at risk if you're approaching 28 weeks. And then you get to a consensus with OB that, yeah, once we get to 28, 29 weeks, we are going to deliver this baby. Of course, that baby's going to be in the NICU for several weeks, maybe months, but the survival of that baby is better than 95% if we can make it to 28 weeks. Once you get to 34 weeks, really the survival for baby is really, really good. So now, let's say you have a patient who's 34 weeks and has, let's call it non-reassuring labs from a renal standpoint, usually you and OB can come to a consensus on those patients, even if it's not high stakes, right? Even if the creatinine's not blasting off. But if you have some, let's call it non-reassuring data from the renal labs, if you got to 34 weeks, you might really relax at that point and have a consensus from OB that let's just deliver the baby at this point. Trying to go all the way to term has diminishing returns. If you're concerned and being pregnant, eyes your hands, then let's go ahead and deliver. So those are things to keep in mind. 28 weeks, really good survival, although long NICU stay. 34 weeks NICU stay, but survival is approaching, term deliveries at that point. Then those are numbers to be aware of. All right, questions about those?
Dr. Sam, can I make a comment?
Yeah.
So nephrogenesis for a baby also like complete around 34, 36 gestational weeks. So babies who are born prematurely before that, like they are at higher risk for like CKD later in life, and then they are shown to have some like higher risk of hypertension of lifetime. But that doesn't really, I mean, that's not going to really decide on like whether they should deliver or not, because that's still maternal and baby safety at that moment, but just something to think about if the mom is asking for those.
Thanks for sharing that. Yeah, there's a pretty um, let's say there's enthusiasm for the conceptual the concept of nephron endowment in later CKD outcomes. So I think that is sort of I don't kind of hot topic, I guess, in nephrology, that nephron endowment predicts CKD risk later on. And so preterm deliveries, as Peishwan has highlighted, is a risk factor for CKD. But as she softened as well, is that, it's generally something to, inform your patient about, but generally is not a major consideration in the clinical decisions that you're making for your patients who have these, these dicey scenarios that you're trying to parse. CKD, a statistically increased risk of CKD, not a certainty, right? But a statistically significant, modest increase in risk of CKD in the preterm individual who later develops CKD in life is not typically going to be a heavily weighted feature of making your decisions. All right, so moving on, in the limited time, I'll go over to 15 minutes. Let me see what we want to cover in this scenario. I think preeclampsia, let me touch base on preeclampsia on things that you may make the call of. I really highlighted already that, how to, diagnose preeclampsia. It certainly is based on a 20-week threshold. But we typically diagnose preeclampsia with blood pressure criteria, and typically proteinuria are the manifestations. You can have features of severe preeclampsia when you start developing worsening renal function, thrombocytopenia, worsening other organ dysfunction, such as CNS signs. And then another thing that we sometimes use and is helpful as you're parsing through the differential diagnosis is a serum uric acid. So interestingly, uric acid levels are typically low throughout pregnancy, but we see modest increases in uric acid during the course of a preeclamptic pregnancy. This is less useful, but low urine calcium on 24-hour assessment is also somewhat characteristic of preeclampsia. The thing that I want to highlight that is sometimes in the realm of the nephrologist practice, and that is preventing preeclampsia in your patients. Again, what the patient that comes to my mind is the lupus patient who's planning pregnancy. It's not uncommon that I have initiated aspirin. I'm not waiting for the obstetricians to do that because of the risk of preeclampsia in our patients, either with CKD or in the lupus patient. Okay, so you would have to go through some of these risk factors for preeclampsia. I've highlighted some of the high risk features with an asterisk. So you'll notice some of these that you're going to certainly be keeping in mind and encountering, that is having CKD, having antiphospholipid antibody syndrome. Lupus is I would say, a modest risk factor for preeclampsia, and then which I've summarized as just connective tissue diseases and put an asterisk by it. And having preeclampsia in a previous pregnancy would be another moderately high risk factor. Okay, so if you have these features with the asterisks, I'm having a hard time saying that this morning, then you could certainly make an argument that this patient should be considered for aspirin therapy if there are no contraindications. With these other more minor risk factors, if you have a multiplicity of those, that might also tilt the balance to initiating aspirin in that individual. Okay, so that is a call that I sometimes make. And then I think the others are surrounding blood pressure management, and we've talked a little bit about that already. Okay. The next place that I'm going to go in the limited time that we have is some of the medications that you safely can use throughout pregnancy. Let's go over that. That is certainly high yield. And of course, that ACE inhibitors are contraindicated in the later phases of pregnancy. You might also tend to get people off ACE inhibitors even before conception, you can actually make an argument that if you're very attentive and able to peel off an ACE inhibitor with the first missed period in somebody who has regular menses, you can make an argument that ACE inhibitors can be continued up until for the early first trimester. Okay, so originally we've all espoused withdrawing ACE inhibitors prior to conception, but if you look at the data, early first trimester exposure to ACE inhibitors does not appear to be associated with teratogenicity. I personally do not ever keep people on ACE inhibitors, and if they're planning pregnancy, and I just say, tell me or stop that ACE inhibitor at the first missed period, but you can theoretically make that argument to do that. Okay. Now, we clearly have evidence that second and third trimester exposure to ACE inhibitor is associated with a number of complications. Many of those complications are simply grounded in the fact that the baby with ACE inhibitor exposure develops acute kidney injury. And so they develop reduced urine output. Urine output is a major contributor to the amniotic fluid. And so when you get reduced amniotic fluid, you get some of these features that, you might summarize as Potter syndrome, where you can have, these tethers where you have amputation of limbs in the baby, or a hypoplastic fetus or baby without full maturation of some organ systems. Now, we do allow for the use of ACE inhibitors during lactation. But you typically need to switch the mom to either captopril or enalapril. Obviously, enalapril would be easier to dose since it doesn't require BID or TID dosing. And I personally don't give captopril or enalapril for mothers to preterm babies. So if I have a baby who's in the NICU and predisposed to volume depletion, I do not want that baby getting even that small amount of enalapril in maternal milk. Okay, so if a baby is thriving, then I don't worry so much about the modest or the tiny bit of exposure in breast milk of that enalapril or captopril. Okay. So that's my rule of thumb. Again, if baby is not thriving, certainly the NICU is by definition a place where a baby is not thriving, I don't give mom enalapril, even though there's only a small amount that appears in breast milk. Okay. Now, yeah, I think that's enough. Glucocorticoid, unless there's questions about ACE inhibitors. Okay, then let's move on to glucocorticoid use during pregnancy and lactation. Generally speaking, prednisone is considered a relatively safe drug, although there is an increased risk of cleft palate. Here it is, cleft palate, with particularly first trimester exposure. So prednisone is okay. But again, mother needs to know that with first trimester exposure, there may be an increased risk of cleft palate. And then also later during pregnancy, you might expect these phenomenon that you might have maternal diabetes, that's a higher risk. And then you may have also complications related to premature rupture of membranes or chorioamnitis. Okay, so that's another risk factor that's probably related to premature rupture of membranes. Okay, and then just the immune suppression that is coincident with corticosteroid use. Okay, now we don't use much dexamethasone, but I've had some patients getting dexamethasone, and I just had to make sure that we switched them over to prednisone, because you'll recall that these so-called modified or halogenated glucocorticoids are not able to be metabolized by the placenta, and so you get more fetal exposure to these next generation corticosteroids. And that's used, as you recall, for fetal lung maturity. When you want to make sure baby gets more glucocorticoid exposure, for instance, in a preterm delivery, you recall in medical school and residency or medical school that obstetricians are giving mother betamethasone to enhance fetal lung maturity. That'll be a way to memorize that there's certain steroids that cross the placenta more readily. Steroids do appear in breast milk, but we don't think of it as being much, and it seems, very appropriate to continue to breastfeed, even though you may be receiving glucocorticoids. Questions about glucocorticoid use in pregnancy? Let's then go to azathioprine. This nomenclature of pregnancy risk is actually old and outdated, but I think still it's useful. And I think many of us have still thought of, pregnancy categories as a means to convey safety to your patients. So D is bad, actually. And so azathioprine was carrying the pregnancy risk category D. And that being said, we have a long history of using azathioprine safely throughout pregnancy. Why? Because there is some placental metabolism of azathioprine to inactive metabolites like thiuric acid. But there is clearly still some fetal exposure to the active drug. So this is not an impenetrable wall that results in no exposure of azathioprine metabolites to the baby, but there is some partial protection from that. There's also the fact that the fetus lacks one of the enzymes that converts azathioprine, you'll recall, is a prodrug. It's actually not an active drug. Azathioprine is converted to 6-mercaptopurine and then on to other active metabolites that cause RNA and DNA synthesis inhibition. So why does it carry this category risk D? Probably guilty by association. That is, patients receiving azathioprine more likely have medical diseases that are complicated, and those are more likely to be associated with prematurity or other adverse fetal outcomes. And so this risk with azathioprine is, again, probably guilty by association. We, in large part, view azathioprine as a very safe drug to give patients who have, for instance, lupus or are immunosuppressed for maintenance of the health of a kidney transplant. IVIG is considered, questions about azathioprine? IVIG is considered a safe intervention. There is placental transfer of immunoglobulin, as you would expect. That happens with normal physiology, and we rely on that to give baby some immunocompetency early in life. We rely on mom to be giving us those good immunoglobulins both through placental transfer and through secretion in maternal breast milk. And so it would be expected that if you gave IVIG, some of that or a lot of that is getting to the baby. And there is a risk for some hemolytic reactions if this antibody targets, that is in pooled immunoglobulin, happens to target the fetal red blood cell, but that risk is relatively small. Calcineurin inhibitors are safe to use during the course of pregnancy, and so we review those as relatively safe. and with pregnancy class C. Again, there is some why not completely safe pregnancy A and B. It's because, again, more this guilty by association. Again, individuals that are receiving calcineurin inhibitors have medical comorbidities that may put the baby at risk. That being said, these are vasoconstrictive drugs, and so you need to, avoid the severe or marked elevations in these calcineurin levels for fear of placental insufficiency. But in general, the course of pregnancy is characterized by a reduction in calcineurin levels. Keep that in mind, because if you don't, once your patient gets pregnant and you're managing a condition that relies on therapeutic levels of calcineurin inhibitor, it's quite possible that that patient now can be subtherapeutic, either resulting in a kidney transplant rejection or a relapse in their FSGS if you're managing that with calcineurin inhibitors. So expect that drop in calcineurin inhibitor levels, make the necessary measurements and dose titrations, anticipating those changes that are to occur. Okay. Now, there is detectable cyclosporin and tacrolimus in breast milk, but generally the exposure to the baby is modest. And so it's not, it's not necessary to completely exclude lactation in your mother who wants to breastfeed and needs to continue taking their calcineurin inhibitor. There are these increased risks of hypertension and diabetes, probably from the known side effects of calcineurin inhibitors that is causing hypertension and diabetes. Okay. We typically think of tacrolimus and cyclosporin as interchangeably safe in pregnancy. The data is more robust for safety of use with cyclosporin, just simply because it's an older drug. But I would never really switch somebody from tacrolimus to cyclosporin based on that nuance. So we'll go through these last few drugs. Rituximab, I've safely used throughout pregnancy in a patient. There is placental transfer. It too is an immunoglobulin. So theoretically, that will cause immunodeficiencies in the baby, but those would be transient as well. It does cause B-cell depletion in the neonate. But generally speaking, we think of this as being a relatively safe drug to use, for instance, in the lupus nephritis patient who may have limited options for treatment, or in an ANCA-vasculitis patient, for instance. Mycophenolate we clearly do avoid in pregnancy and lactation, and this is considered pregnancy risk category D. Notice again, that is the same category of azathioprine. However, we think of azathioprine clearly being much more safe, and we switch people from mycophenolate to azathioprine quite routinely in order to reduce risk of teratogenicity to the baby. Cyclophosphamide, we generally avoid, though you can say that in life-threatening disease, you may justify using it, particularly in the second and particularly the third trimester of pregnancy. Remember, though, in those third trimesters of pregnancy, if you can get baby to 28th week or the 34th week, then this would be preferable than giving that mother cyclophosphamide while the baby is still in the oven, let's say. So I think, again, use that judgment call where I might need to use cyclophosphamide, but if you're close to these thresholds where we can deliver the baby anyway, that may be your window where you're going to use cyclophosphamide with more reassurance without any fetal exposure, obviously, once the baby is out. We don't give cyclophosphamide during lactation. All right, questions about pregnancy and the kidney? All right, so
Dr. Sam, can you hear me?
Yes.
Yes. So when do you decide to start dialysis in a pregnant patient? So
okay.
Is that different than the general population? Or like when do you trigger that saying like, okay, we need to start dialysis? Is that just the BUA number? Is that like what makes you decide that?
Yeah, that's a great question. And that's a question that, not just nephrology trainees wrestle with, but nephrologists wrestle with. In fact, I engaged on this very same question with Bethany Rame, who currently is managing a patient in the outpatient setting who's got CKD and is wrestling with whether to start the patient on dialysis. So let me get to this in your field guide. Where do I have it? Dialysis and pregnancy, so we can kind of see it and discuss it. Here we go. So the goal, based on some published data, is that if you have a patient, so this is a different question, but we're going to segue to your question, Mauricio, that if I have a patient on dialysis and they become pregnant, I should dialyze the heck out of them with a goal to get their BUN less than this 45 range. And then some even experts have suggested that it should be less than 35. This is based on a study, very flawed study in arriving at a rational conclusion. It's a study of Canadian patients who were either on, very long, like in-center dialysis where they slept in the dialysis unit and got long dialysis treatments, or they were on 5 to 6 times per day dialysis treatments where they were getting very unusual dialysis treatments, and comparing the fetal outcome for patients dialyzed that way in a very novel way compared to patients who were to fetal outcomes in traditionally dialyzed patients in America. That was really so using historic controls in and comparing that to patients that were managed in a very novel way. And they found that if you dialyzed patients with very long dialysis treatments and many times a week, and you achieve threshold BUNs in the 30s, that those individuals had fetal outcomes that were really quite good. And it was based on a very small subset, single center analysis. Again, using historic controls that weren't even their historic controls, using an American population compared to this Canadian, very unusually managed patient population. So some people have then used that study and some of these other studies in dialysis patients to say that if I have a CKD patient and their BUN is 60, I better dialyze them. I better initiate dialysis in that patient. I view that very differently. Okay, I do not do that. I personally do not do that. You can justify that. That's what some nephrologists do. But that question has never been answered. Early initiation of dialysis in an advanced CKD patient versus no dialysis has not been answered. And I'm highlighting that even attempting to answer how hard to dialyze a patient has very limited data that informs it. So I would be very cautious with saying, okay, let's use these BUN thresholds to make a decision to initiate dialysis. Because in my view, a CKD4 patient who's trucking along and well-controlled blood pressure, good volume control, no uremic symptoms, is a less risky pregnancy than a patient who's getting a tunnel dialysis catheter placed if they don't have a fistula and going to a dialysis unit 5 times a week where we could potentially be causing hypotension every time we ultrafilter them. Okay, so I personally do not dialyze somebody simply because their BUN is above these thresholds that typically govern the dialytic management of patients who are pregnant. Okay, I think I had one other thought and it's escaped me. What was the piggyback thought on that? Oh, now if the baby is small for gestational age, right? They're having serial assessments by, fetal ultrasound. That is a different patient. If I'm seeing those sort of adverse biomarkers of fetal outcome in those scenarios, I may consider, okay, let's go ahead and, we don't know whether this azotemia mom is really causal in these, what we're observing on these assessments of baby health. So in those instances, I might go ahead and initiate dialysis. That being said, I don't know that I'm doing something good, but at least I have some other biomarker that says, other than some arbitrary BUN, that says maybe there's some good to be had by lowering the uremic milieu. Does that answer the question?
Yeah, thank you.